Case number 8, again, surgical specimen. It was a subcapsular nodule that was discovered during surgery for pancreatic cancer. So there was a frozen section, and you have now the specimen that was fixed in formalin. So let's go to the slide. So this important case, this nodule that was resected during intra-abdominal surgery, it was suspected of metastasis. You can see here at low magnification that the nodule here has a subcapsular localization. You can see obvious steatosis in the adjacent liver parenchyma. And now we'll take a closer look at the nodule. You can see that there are some inflammatory infiltrates at the border of the nodule. And when we take a closer look at the nodule, we can see that it is composed of small ducts, tortuous small ducts. There is no significant atypia, no increase in the nuclear to cytoplasmic ratio, no hyperchromasia. And what is also important in this case, maybe you have here an artery, and there is this duct that maybe does not clearly look like the other, and maybe it's the remnant of a portal tract. And it's important because these lesions often develop in the vicinity of a portal tract, and you can usually identify the portal tract at the center of these lesions. So the appearance is everywhere quite the same. You have here also inflammatory infiltrates, all these ducts, no or only very little atypia, some edema. And the diagnosis in this case is pretty straightforward. It's a bile duct adenoma. The main differential, of course, is metastasis from adenocarcinoma. It can be tricky on frozen section, and I will include in the upcoming seminars some frozen sections of metastasis or bile duct adenoma. And also another differential diagnosis is bile duct hamartoma, which are called also von Meyenburg complexes. And the appearance is not quite the same. In an hamartoma, the bile ducts are more dilated. You can see some bile plugs, and the stroma also is more fibrous, more dense. So it's important to be able to recognize these lesions and to know this entity, even for people who will not do liver pathology as a daily practice, because it's completely benign. There have been some case reports of transformation, but it's very, very rare. And at the molecular level, this lesion was first suspected to be reactive or a kind of malformative lesions, but now we know that it is more likely to be a proliferation, a true neoplasm, because in half of these cases you will find a BRAF V600E mutations, and you can also identify these mutations if you have the anti-BRAF V600E antibody, and you will see a positive cytoplasmic staining. So it may help a little bit for the diagnosis. And of note is that bile duct hamartoma, von Meyenburg complexes, do not have this mutation.